Hi, this is Rhonda Orndorff, and today I'm going to be talking about a practice change project involving implementation of lifestyle counseling in the primary care setting and its effects on weight loss among obese adults with diabetes. This is in partial fulfillment of Nursing 712 at Colorado State University, Pueblo, under the direction of Professor Dr. Kathy Coram. So the significance of the problem. So as we know, obesity has become a public crisis. In the United States, the annual cost is $147 billion in medical costs. This is projected to double in about 4 years. Industrial cost is between $3.38 to $6.38 billion annually, and this involves absenteeism and decreased productivity secondary to those obesity-related illnesses. Statistically, in the United States, we have about 93 million adults who are affected with obesity. In Colorado, we have a population of about 20 to 25% who are affected. And then in Pueblo, Colorado, our population has about 30% have obesity. And this is secondary to lower social economic status, lower education, and lower access to care. Now, as a provider and a nurse practitioner, this is important because it affects the whole individual. So obesity affects psychosocially in the fact that you have higher incidences of anxiety and depression. Metabolically, you have higher incidences of diabetes, hypertension, hyperlipidemia, hypoventilation syndrome, sleep apnea, and cardiovascular disease. And then socially, these people are often stigmatized due to their obesity. I put these are primary care problems, but really these are all provider problems. So time constraints. We often only have about 15 to 20 minutes to address all of the patient's issues. Oftentimes they will come in with one chief complaint, but evolve into 2 to 3 chief complaints, leaving obesity to be on the tail end of the visit or if at all addressed. Sometimes providers or the patient are uncomfortable with the discussion, so patients will not bring this up during a visit, and then the provider may feel uncomfortable with discussing the patient's weight with the individual, so that also will lead to not discussing this problem. So then we look at coding and billing. So we do have a CPT code 99401 and 99402, which is screening and counseling for obesity. To be able to code for this, you have to have face-to-face visit every week for the first month, every other week for months 2 through 6, and every month up to 1 year. To be able to continue using the CPT code, you must demonstrate a weight loss of 5% for this individual. CMS reimbursement for these 15-minute appointments is about $24. You must document the 5 A's, and you must meet all the face-to-face criteria that I just went over. For the patient, the out-of-pocket for a Medicare patient is about $26. So this leads to my question: in adult obese diabetic patients, how does a provider diabetes visit protocol implementation brief lifestyle counseling tool compared to diabetes practice guideline compliance alone promote a 5 to 7% weight loss and decrease hemoglobin A1C over a 6-month period? So this is my case study. So you have an individual coming into your office. His name is DP. He's a 45-year-old gentleman with a chief complaint coming in for a 3-month visit for A1C check. He has a past medical history of obesity with a BMI of 32, hypertension, diabetes, and hyperlipidemia. His current medications are 3 diabetic medications at max doses, lisinopril at max dose, and atorvastatin high intensity at 40 milligrams daily. You check his A1C and it's 8.5%, so you start him on a long-acting insulin of Lantus at 10 units at HS. This is all that your discussion was during the day, during that visit, and you have him follow up in 3 months. During that next visit, he had a A1C of 8.5%, but his BMI increased to 35 kilograms per meter squared. At this appointment, you do ask him about exercise and diet, which he says that he doesn't exercise and he does eat a lot of bread, but you don't go any further. So the opportunities missed during these 2 appointments was obesity counseling and interventions to include diet and exercise counseling, as well as behavioral counseling and close follow-up. Also, depression screening was not included in any of these appointments. And then also there was no education or feedback to this patient regarding his lifestyle changes that need to be in place to improve his A1C and overall obesity and, I guess, overall health. So this is a research review table, and I only put some of the key articles on here. And the key takeaways from this table are, number one, Leah 2015 shows that often providers miss documentation regarding BMI and obesity. So with some kind of prompting, they did increase their compliance of documentation from 4.8% to 35.2%. The other key articles on this review demonstrated a control group versus a behavioral counseling group, or even an extensive behavioral counseling group. And what we see in these groups is that the control group did lose weight, but when you compare them to the rest, there was a significant weight loss in the behavioral intervention groups. Also, their diabetes or their glycemic control was much improved as well. Another article, Costanza et al., was interesting in the fact that BMI greater than 25 kilograms per meter squared did have higher rates of cardiovascular events, but had lower mortality risk overall. These individuals were obese and did have diabetes as well. But what's interesting is the patients that had a BMI greater than 30 actually had a similar cardiovascular risk and a similar mortality risk compared to those with a normal weight person. So looking at the practice guideline, I use these in practice, so that's why I focused on these. The American Diabetes Association says that modest and sustained weight loss has shown to improve glycemic control and reduce the need for glucose-lowering medications. Again, it notes that BMI should be calculated and the patient's readiness to lose weight should be assessed at each visit. Behavioral interventions need to be put in place thereafter, so these may include physical activity, diet, pharmacological therapy, which would be like Orlistat, Belviq, and Contrave, or do they need a referral for bariatric surgery? Looking at the American College of Cardiology and the American Heart Association, what we find is similar guidelines or similar recommendations, but what they also preface is a team approach. This would not only involve all of providers involved, but it would also involve a dietitian, a physical therapist, and whoever is also involved in the patient's weight loss journey. The reason this is important for the American College of Cardiology is diabetes is associated with patients with diabetes. About 65% of them also had cardiovascular disease. And then obesity puts you at higher risk for diabetes, for hypertension, hyperlipidemia. All of those are cardiovascular risks. So that's why it's super important for the cardiology department to have these guidelines in place. And then I also wanted to go back to the Centers of Medicare and Medicaid Services. I again wanted to preface the fact that reimbursement for obesity screening and counseling is $24. Out-of-pocket cost for the patient is $26. So the gaps and limitations. So when we look at practice and guidelines, there's an obvious gap between what is said, what are recommended, and what's actually done. This is due to time limitations during the visits to discuss obesity and weight loss strategies. We've already discussed that reimbursement is a concern leading to lack of standard obesity screening and counseling services. So as a provider, what I'm looking at is my reimbursement for this type of service is $24. But I can also have an acute patient come in and I can get reimbursed at a higher rate for that patient versus this patient coming in for obesity screening and counseling. Also, documentation completeness. So not only do we get reimbursed, but we have to really comply with all of these documentation things that they need to be reimbursed fully. And so really, is that cost effective for not only the provider, but also for the patient? So here is the practice guideline. This is the ACC practice guideline, and just to have you look at and review. So what we missed on GP was, one, we did evaluate his BMI and his weight, but we missed the opportunity to assess his readiness to make lifestyle changes, and we also missed the opportunity to discuss what his healthcare goals are and what he's really looking to do with his health. So one, is this patient looking to avoid insulin therapy? Is he looking to be able to walk a mile? And how can we help him with this? And so we missed that opportunity to make appropriate referrals and adjust those lifestyle interventions to make him successful. This all again goes back to the 5 A's framework. The MP core competencies. So this is something that we all do on an everyday basis. So for GP, we have really looked at this patient and said, what are we doing in practice, and what are the guidelines saying, and what are we going to do about it? So we look at literature review and we implement these changes to for better outcomes, for better patient outcomes. So we've addressed several of the MP core competencies here. I think we've addressed most all of these, but specifically, we've addressed practice inquiry, quality competency, and scientific foundation competencies. Now, moving forward, you need to take this into a leadership role and say, this is what the guidelines say, this is what we can do about it, and this is what I've been doing, so this is what we can do moving forward. So you can be the champion to move this practice change forward. So looking at the theoretical framework, first, I want to talk about homeostatic theory. So this says that healthy individuals maintain homeostasis with inward and outward stability. So if any of these factors are disrupted, for instance, this patient has diabetes and it's uncontrolled, homeostasis is disrupted. So this leads to a further perpetual negative feedback loop. So his diabetes is out of control. He goes home. He feels depressed. He continues to eat more because he's depressed. He comes back for a follow-up visit, and his A1C is still uncontrolled. So it's a constant continuation of this disruption of homeostasis. So if we get one of these back into alignment, then most all of the other ones come back into alignment, and homeostasis is restored. So then we look at the 5 A's framework. Now this is something that I've referenced multiple times, and it's used for obesity and other behavioral interventions. So first you want to assess the patient and their readiness to change. Then you want to advise them on how they can change and what interventions can be put into place to make that change. Then you agree on that change and you move forward with timelines and goals, goal setting. And then you assist the patient in any way that you can with referrals and interventions in place, such as pedometers, etc. And then you arrange follow-up and continuation of this pathway. So in conclusion, obesity is a complicated diagnosis with implications of many other comorbidities, indicating the need for primary care intervention. This will overall improve patient care outcomes, it'll improve healthcare costs, and it will decrease the irreversible metabolic changes. So we can do this by using the 5 A's framework that I just discussed with you. And then by doing so, we can utilize the literature review, which indicates the brief lifestyle interventions to benefit weight loss. This is also supported in guidelines, so really we're following guidelines by doing this. We do need to find a standardized intervention to promote weight loss, therefore decrease in other comorbidities. So there is room to figure out a standardized intervention to help promote weight loss. So these are my references, and I apologize if I went too fast. I knew that I was tight on my time. Thank you for listening, and I look forward to your comments.